it to 2 now?
It's
Yeah, 2 now. It's 2 now. So should I go ahead?
Yeah, one.
Okay, let's start. There are 25 people I'm letting in now.
Mm-hmm. It's now 2 minutes after 2. We want to take the opportunity to start on time so as to maximize the input. Stephanie?
Yes, I'm here.
Right, and I think we should start now.
Yes, you may go ahead.
Yes, thank you. Well, first of all, we just want to center ourselves in this conversation, this important conversation, by offering gratitude and appreciation that we are all here together. We have all been through a very trying period. We are still going through a very trying period. And we have to recognize that not only have we been it together, but we are standing together to push through, and we are full of gratitude for life and for the solidarity that we have expressed to each other at an individual and at a collective level. We also want to extend thanks and commendation to workers at all levels of the health sector who have made sacrifices in different spheres, and I'm talking of health sectors from community to the national level and in their various categories. And we have 2 representatives here with us today, and through them we want to extend that appreciation to all categories of workers who, despite challenges and difficulties that we will not hide, have done what is good and positive, with errors, of course, but to sustain us through this very trying time. The theme of our discussion is Lessons of COVID for the Ministry of Health and Wellness's Vision 2030 Strategic Plan. And this discussion is organized by what I would call a company of women, a group of women who belong to different organizations and have had long experience working with one another on various issues for feminist development, gender responsive development, and who have determined that the time is right for us to try to make an input into the issues that confront us. And so we've had 3 discussions so far. We've had discussion certainly on the economy, one that has dealt with women, how COVID has impacted women and the issues that arise. And last week we had one on education, and then today we're having this one on health. And we're doing this with technical support from We Change, represented here today by Stephanie Brown and Paige. And we have a very distinguished panel of participants. First of all, and I'd like to introduce them, Carmen Johnson, who is the third-term president of the Nurses Association of Jamaica. Carmen has been in nursing for over 29 years. She's in midwifery, focuses on midwifery, but in recent years has been looking at issues of health management, has been in management. Then we also have Pauline Russell Brown, who is the CEO of Jamaica Family Planning Association, and that is a very long-standing organization that addresses sexual and reproductive health and rights. And they have two branches, one in St. Anne's Bay and the other in Kingston. Pauline herself is a specialist in health policy and research. And we also have and welcome Dr. Elon Beckford, who is the president of the Jamaica Medical Doctors Association.
Thompson.
Beckford, Thompson, of course. Sorry, thank you for the correction, Thompson. Elon. Elon has some 13 years experience as a doctor, and he's a urologist in terms of his specialty. We want to extend apology and solidarity with our fourth panelist who was to have been here, Janet Silveira, who we hoped would have been able to bring up a perspective from the West. Well, she has had to deal with some serious family emergencies and has called in to extend our apologies, and we give her our prayers and hope that things will stabilize for her. Now, what do we want to achieve out of this discussion? First of all, we want to make people familiar with the fact that in 2019, the Ministry of Health and Wellness published their Vision for Health 2030, which is their strategic plan, and they invited public discussion on it. And what we are doing is seeking to have input from as wide a cross-section of persons as possible into the strategic plan. And our aim is to be able to synthesize and make a presentation alongside the other issues that we have been discussing to the authorities with a view to influencing the policy, for example, in relation to health and the strategic plan. So what we want to do is to be very pointed in terms of gaps that we think need to be filled or areas of emphasis that we think need to be strengthened. And although many of you have not read the strategic plan, we sent copies to you, we would like you to speak to your experiences, those of not only panelists, but you yourselves who are other participants, based on our experiences under COVID. What are some of the things that any strategic plan should really embed? So that is the spirit in which we are having this discussion. I'm going to ask
something to eat.
I'm going to ask now for the strategic plan, the summary, the executive summary to be put up, and I'm going to lead you through it very quickly, and then we'll go to speak to the panelists. Yes, please scroll down for me, Stephanie. Right. The vision, right? You notice the vision says healthy people, healthy environment. And the mission is to ensure the provision of quality health services and to promote healthy lifestyles and environmental practices. Moving along, they have this standard comprehensive essential benefits package, which focuses on patient-centered life cycle approach to health, universal health coverage, and universal access to health. Moving along, Then there's the Health Service Delivery Network, which is speaking about reviving primary health care, which is talking about establishing community districts and comprehensive categories of centers, reducing the number of categories of health institutions, and a third component speaking to incorporating rural outreach networks to support screening and basic care and preventative measures at the community level. Moving along, next, then there's a whole matter of financing. They want to see, the plan says that they want to achieve a gradual increase in central government spending on health to 6% of GDP. And this 6% is a PAHO benchmark, and you should know for information that it's now 3.4%. They also want to establish a healthcare reserve fund and also a longer-term national health insurance scheme. Moving along, looking at the financing thing for a bit though, one of the things that I am inviting us to consider is whether these are realistic objectives, given the fact that at present we are seeing that most areas of the budget have been cut because of COVID expenditure, although debt repayments represent some 0.3% of GDP, in other words, $7 billion. What are these? Is it desirable to target a 6% of GDP? And what would we need to do? And although financing might sound like an area that is not in our competence in general, we have to take a common sense approach to it, to ask ourselves, is it a realistic goal to put that you're going to achieve 6%? And shouldn't we talk about ways to achieve 6%? And should we affirm as civil society that 6% is desirable? Moving along. On the issue of governance, we want to focus on efficiency, resource sharing, improved rationalization, and accountability. That's what the plan says. They want to see a rationalization and restructuring of the regional health authorities, as well as of the ministry itself, to focus on technical quality of care, monitoring and evaluation, and internal audit issues. Then they also have two ancillary areas that speak to human resources for health, where they are talking about they want to put in place policies to reduce clinical staff migration, provide positive labor environment, improve the capacity to manage, monitor, and evaluate their training needs, and ensure availability and quality of highly trained staff. And finally, they want to deal with the issue of infrastructure and including public-private partnerships. Definitely in terms of the principles that they have put forward in the next slide, please. The guiding principles in the strategic plan are equity, collaborative or collaboration, integrity, responsive, respect, and transformational leadership. And the question that we have to ask you as participants out there, if you go back to those, please. Are you satisfied with these guiding principles? Do they take into account sufficiently our experiences under COVID? What would we add? What would we emphasize? What would we reduce? So those are the basic framework that we have seen in terms of the strategic plan. And now we are going to turn to the wider discussion. Thank you, Stephanie. The first question that I, however, want to ask our panelists is more on the side of half a minute. How you feeling? I mean, coming through this experience, what's on your mind right now as Jamaican persons in this context of COVID? Let's start there. Nothing long, and we have an alphabetical, so we're going to start with you, Carmen.
Thank you, Mrs. Bassan. Good afternoon to all present. Just want to say thanks for inviting me to be a part of your esteemed panel, and I will truly seek to see how well we can represent the populace and healthcare. How I feel regarding COVID is that we are very grateful and thankful for how things have unfolded in Jamaica, meaning that we are blessed, whether or not we want to see it in that regard, because things could have gone much worse. We are a little over 100, 611. Our hospitalization rates were very low. Those were, our death rate is very low. Yes, we have lost them, and we sympathize with those who have lost their loved ones. And if we hadn't acted in the manner that we acted and in the time, maybe it would have been worse. And so going forward, I am happy for the national response that we had, for the healthcare response that we have had, and also for the effort of our healthcare staff, our healthcare workers. And we just want to say thanks to all our healthcare workers who have come together to ensure that the country is able and was able to respond in the manner that it responded. And despite that they are overworked and overburdened, they have really stood up to the test of time, and they have come through ensuring that the populace remain intact and that we are able to survive this portion of COVID. Hopefully the second wave, if it should come, won't be worse than the first, and that we'll be able to cope as well as we have done now, or even better.
Thank you, sister. Pauline, how are you feeling? What's on your mind? Pauline? Does she? Yes. Yes. Yes.
Okay. Like Carmen, I'm very happy, that we have managed to come through this well. And we compare ourselves to Haiti, for example. And when we look at their figures, it's really frightening. We could have been there had we not done the planning and the community education, I think, that we have done. But I have concern, and my concern in two areas. One related to what is anecdotal at this point, the increase in sexual violence, especially towards children. And the second concern for the healthcare providers. We have managed so far to do very well in that regard. But if there's a second wave, can healthcare providers survive in the same way that they have? So those are the areas that I really want to focus on now. Concern for children especially, and sexual violence issues, but also women for intimate partner violence. Those seem to have gone up. And concern for the healthcare providers themselves and their safety.
Okay. Elon?
Afternoon, everybody.
Mm-hmm.
Especially to the panelists. Well, I want to extend thanks again, Mr. Vasu, for inviting me to this panel discussion. I echo similar sentiments of the two previous speakers. I am a little bit concerned about how much what has gone on with COVID-19 will derail some of the plans that were already in place and that were being planned. We are yet to see how it will affect the health sector going forward. I think that is going to be the major concern. I think when we look at the numbers, we have done a good job in managing the numbers. We lost 10 lives, so that's always going to be significant. And I think the entire health sector, the workers have stood up tall and have really come to the fore. Primary healthcare workers, especially those persons who are doing, contact tracing, doing all the groundwork. And I want to express thanks to all of them, from the doctors, the nurses, the contact workers, everybody in the health sector who has done their part. And I think we have come together nicely, but the work is still not done. We have a little ways to go because we weren't in a perfect place before, and we certainly are not in a perfect place now. So we have a lot of work to do. We have a lot of lessons to learn. And I think that is the most important. And I think that's part of the reason why I was so excited for this. Because my message is that we have lessons to learn, and I hope we learn them after COVID-19 and onwards. Thank you.
Excellent, excellent. We are going to call on you to begin to identify some of those lessons, because the question that I want to put, the first question that I want to put to you all is based on that experience that you have spoken about and in terms of COVID, what are the positive areas of action that needs to be emphasized in any strategic plan? And you've seen the basic outline of the strategic plan. And what are the gaps to be filled in the strategic plan based on the lessons learned? Now, can we deal first with the positive actions that we can hold up and that need to be strengthened first? Beginning with you, Carmen, what are the positive actions in terms of planning and moving forward that the lessons of COVID point us to?
The first positive that I want to bring out, and I'll take it from the level of the strategic plan guiding principles, and that was being responsive. When we came out and spoke about our concerns with our airports, our seaports, and how we need to improve and to ensure that we are protecting our borders, though it had come across in to persons, to our policymakers, though they took it in a negative light, because of our continued efforts and our continued communication and our continued requests, they became responsive. And in becoming responsive to the threat that there was, our request to ensure that we are protecting ourselves and protecting the populace, we are in the position where we are. And in saying responsive, what I meant is that we were able to determine how do we now get our healthcare facilities, commence the communication, commence the preparation, get our airport healthcare staff up and ready with the equipment that they need, get them start being educated as to what to look for and to be paying more keen attention to what was happening in China and to what was happening in Italy, and to recognize that we will be affected and it is only a matter of when. And so having reached that point where we accept that we needed now to really look at what we were doing, the system responded. Our national, the Ministry of Health system responded, and nationally the Prime Minister and others responded and put measures into place immediately. The team look at to contain, let us look at how we quarantine and how we isolate, how we pull this subset out of the general populace, get them out of the way, treat with them, and to ensure that we are minimizing the multiplier effect and that we are flattening the curve as we needed to. Also being responsive, that we recognize that what was happening in other countries, if we don't respond to our borders, our seaports and our airports, then we run the risk of things becoming out of control where our healthcare system would not be able to cope. And so with that guiding principle, I see that as one of our positive, and our hope is that they will continue to be responsive. Though we were not fully responsive, there's still room for improvement, but nevertheless, we have that response. A little bit late out of the block with the communication, but nevertheless, we had the communication. The ministry re-strategized, and then they really pump up on the communication to the populace. And again, once they recognize that the complaints were coming in or the requests to address a certain area, they became responsive, and the team started producing the communication material, getting the communication out there in the announcements, in the videos that they put out that is applicable to our setting, where the common Jamaican man could understand and understand their role to play. And so for me, those are some of the positives that came out of the COVID-19. Oh, you said the positive. We can look at the
Right,
next.
yes. Thank you. Pauline.
Yes, I want to focus on what I consider the integrity, the quality of the information that we were getting. Now, questions still being raised about whether or not they're in fact accurate, but from where we sit as an organization, it appears that in fact we were kept well up to date and apprised of the situation as far as the number of cases, the number of imported cases, the number of deaths, the number of persons who had recovered, the percentage recovery rate, all of that. And for me, that it gives us confidence that someone was keeping track of the data and in fact was sufficiently confident in the data to share it with the wider public. So that for me says there is some integrity in the system, in the data system. I think this COVID experience really shows us public health in action. It oftentimes, not always, and as previous speaker said, there are areas that can be improved, need to be improved. But we saw what appeared to be a very well-oiled machinery in place. And so that is something we need to commend the Ministry of Health and other government agencies, because there were other partners working together with Ministry of Health on this. So the integrity and the quality of the data and the confidence the government had to share it with the public, that for me was a very important aspect of the COVID experience.
Okay. Elon, what about you?
Well, I realize I'm the thorn among the roses. I think there are some positives for sure. I think from a national level, the communication with the population has been very good. We have been getting regular updates, and it emphasizes the role of primary care, as was said before. And I think communication definitely has been one of the strengths with regards to national communication with the population, reaching the people. And it speaks to the role of leadership and governance. And people, we have to have strong leaders, and that's the role of the government, to lead, and they have to be strong. So I want to applaud the government for that. The other strengths have been really the human resource element. The persons who have made, the technocrats who have made some of the tough decisions, the persons in other ministries outside of health, the Ministry of Education, they had to, close the schools and have an immediate plan put into place. We have to think about the vulnerable groups, the children. And certainly, with the schools closing, I think it had a major impact on the numbers that as well. I do take the point about the ports and closing the ports at an early stage and its impact. So really the major positive I think here has been, communication and how the information has gone out to the public.
Good. Before I go to look at the gaps, okay, so let us hope and pray that we overcome COVID in another, or the vaccine is found and we can learn to live with COVID. Are these positives things that you have seen magnified in COVID and need to be emphasized going forward? For example, we speak about communication, but what about communication in terms of the patient who goes into the hospital system? What about integrity of information and data sharing on an everyday basis within the health sector? And the whole question of public health in action. Yes, all these positives that we agree are there. How can we systematize them? Are they things that have just come up because of COVID that it shows our potential, and how can we embed them in our planning and implementation going forward? I don't know who anybody can answer.
From my perspective, Mrs. Vasson, looking at the strategic plan, one of the things that COVID has helped us to recognize is that providing for health and the employees within the healthcare facility is not a burden, or it is not an expense to be avoided, but it is one that we must seek to embrace in its fullest extent and to appreciate it much better. One of the things we recognized coming out of this COVID response was the national collaboration that we had. And so from early, with the Ministry of Health, EOC, EMS recognizing that we need to start the communication early with all the emergency medical services response.
Okay.
When they recognize that we must now start communicating and get everybody on board, they started having meetings early enough so that the sector could recognize that we know all have a part to play and that we must come together. What we want us to recognize and to appreciate is that we have been saying it all along, that health must be seen as a part of every ministry, a part of every sector, and that the provision of healthcare affects and impacts every sector, and not just Ministry of Health, but health should be built into each sector's budget, built into their policy development and how they manage going forward. Too often you hear persons complaining of the air pollution because of mining and other events. Too often you hear about places not being kept clean and that our rivers, our roadways, our drains, etc. has a challenge. And even with dengue, it was brought to bear. And so if we can have this high level of collaboration where everybody, every sector came together to say, let us stand against this war that we have to wage, against the unseen enemy, and to ensure that we win. I'm hoping that COVID will help us to recognize that it is high time and full time now, and I'm happy to have seen it in the policy, that health be seen as a part of every sector planning as we move forward, because COVID touched every sector, brought the economy down to where we have never had it for years. And so that's one of the things that we want to look at and to see where we're going. The other area that I want to touch on is that we have looked at our human resource in health. And our primary care individuals have been under strain and pressure, but this is what they were trained for. They have embraced their role. And one of the things that we recognize is that too long we have been saying that we need the primary care renewal. And moving forward, if we are to continue to survive COVID and any other such pandemic or any other such health challenges that may come, we must move with some speed ahead to address primary health care. We must ensure that we are looking at restructuring primary health care as was planned, how we provide the service and the systems within primary health care to meet the demands, both promotive, preventative, and to some extent curative and promotional, because if we miss that enhancement, COVID is going to be around with us for a good time, because we have had SARS-1 and SARS have been around since 2013 when the numbers decreased, and we still have a number of cases around. We are going to be having greater challenges, and so we must now seek to see how we improve our primary healthcare sector while also investing in the human resource in primary care. Because one of the challenges that many of us don't recognize with COVID is that in COVID, what has happened is that we have, I would say, not abandoned, but we had to reshuffle primary care where many of the health concerns of the general populace were not being met, because you had to pull the teams to go out to do contact tracing, to be educating, to be testing the patients, to be doing what you have to do. And so many persons, many of our functions within primary healthcare were just pushed back. And so persons who would normally go for their family planning, go for their maternal and child health, go for their curative services, you find out that they were pushed back. And one of the challenges that we may face is that as we reopen the economy and persons now see everything has been coming back to close to normal, we are going to have a number of persons who have had their ill health being around when we said social distancing, but rather when we are having that physical distancing and they were afraid to come out, we are going to have an increase in the number of persons with their comorbidities. Over.
Okay. Thank you so much. Anyone, thank you so much for that. Anyone has any further comments on the question of the positives and whether the communication is so forth and whether they went into people, it was shown in patient care. A lot of the attributes that we now see, are they new and how can we systematize them? Anyone want to comment on that before we go to the gaps?
They are not new. They are not new, Mrs. Vassal. It's a systemic challenge that we've been having, where, to put it mildly, that health has been abandoned for years. And despite that, we have been advocating for better healthcare services, better facilities, better provisions for the populace of the country, greater collaboration in attending to the needs of the lower strata of the economy and the middle strata to ensure that health is responsive in a holistic manner. That was absent, and so it is a challenge that we have had before. It's a challenge also with the capacities of our facilities, and so it's nothing new. It's because we have remained unresponsive, and that's why I said before that I'm happy that we became responsive to some extent.
Okay, so to summarize on the positives, what we're saying is that being responsive, being very communicative, dealing with data, sharing and data analysis in a very proactive way, really strengthening public primary health, and also joining up government and mainstreaming health and wellness are some of the things that we saw, the positives that we saw, and these must be strengthened in the way forward. So can we, yes?
The point also to share is that, some of the positives that we experience may have led to some of the pitfalls, as I think Carmen is saying. Some of the areas that we had to be strong in for the outbreak, we left some areas, neglected.
Yes.
What we have to do is to take a proactive approach instead of a reactive approach. And I think for a long time now in health, we have been taking more of a reactive approach to problems. And we really have to start planning. And I think the strategic plan is a comprehensive document that is well organized and well thought out. And we are going to have to really all work together to achieve this if we really want to make it possibly in the 10 years.
Right. So can you continue to talk about the lessons though, to turn to the gaps that we need to fill?
So, with respect to some of the gaps, I share the concerns about persons who have been at home, because we had shut down operations. Let me take it a bit more to my home as a surgeon. We had, stopped doing elective operations, pretty much scaled down is the word I want to use. We had really scaled down because of the outbreak. And, the primary care system, which is really what identifies the majority of cases that would come to us in the hospital. That detection process that would be at the primary care level would be much lower now in the presence of an outbreak, because persons are not going to be going to the health centers, to their primary care physicians to seek help. And we have this notion in Jamaica that once you're not feeling any pain, it's not really an emergency. And there are a lot of malignancies, cancers, lots of problems that can occur without any pain until it's too late. And, I think down the road when the green light is given for the whole health sector and the whole country in and of itself to open, I think we're going to have some challenges when persons come to the primary care system and are eventually referred to the hospital and compounded with the backlog of patients that we have not operated on in the last 3 months. So we are going to face some serious challenges in the hospitals and in the primary care system going forward. We just have to be strong and deal with them as they come.
Mm-hmm.
So that's just one area.
Yes, and you did say that there were a number of gaps and lessons that you had learned. So this is where we'd like you to share them.
Well, one lesson, as I said, we have to stop being reactive. We have to really sit down, analyze this strategic plan carefully. I think we have a long way to go in terms of how we develop a patient-centric kind of approach. And dealing with our vulnerable groups also. So we have to, I think we have placed a lot of emphasis on modernizing infrastructure, because what we've started to do, as you can see, is outsource radiological procedures. We're thinking about outsourcing even surgeries as well. So we're taking a serious look at modernizing infrastructure that has started in some institutions, but we also have to take a serious look at the intersectoral collaborations. So we could use the Ministry of Education to assist with our promotion of health, looking at non-communicable diseases. We need to use other ministries to assist us with the message. We need to just look at a holistic approach to how we can, drive home these points in the strategic plan. The plan is there. They have a plan. We just need to follow the plan and try and do it as quickly as possible.
Okay. Lynette, this is Judy. Can I make a comment?
Sure, please.
Hi. I'm wondering if there is a way we could challenge the government, any government, in recognizing that COVID-19 has, your panelists have said, exposed for all to see the very, very serious weaknesses in primary health care. So they've had to deal with them to a point. So they had to find new resources, in particularly human resources. So we know that COVID will be around for a long time, but we still need an up and running primary healthcare sector. So what is going to happen after? Can we say to the government, the kind of budget decisions you make going forward, whatever else is happening, you cannot allow the primary healthcare system to deteriorate the way it has. And I'm using the word deteriorate generally, right? We know it's not bad in every area, but there's some key areas that COVID exposed. So how would we respond next year for the budget? How could we say that you really cannot reduce the budget again, because there's still work to be done, so that the primary healthcare level of care, as the nurse was saying, remains strong and robust. I'm concerned about that. I really am, because those decisions that are made in the budget have monumental implications for the entire sector, but particularly primary health care.
I want to hold that point, Julie, because Carmen referred to it as the need for primary health renewal, and Elon spoke in that same vein. And I want to marry it with the point also about patient-centric approach to health. And I want to ask, how can we, going forward, marry primary healthcare renewal and patient-centric approach and make sure that it is financed and that it is observed? Because that gap is not there. That gap exists and needs to be filled. The whole business of a patient-centric approach, for example, are the guiding principles patient-centric sufficiently, or are we talking more about systemic systems and frameworks? Is it, what are the principles? So I'm saying, yes, we want a primary health renewal and a patient-centric approach, but we have a budget constraint. So how must we talk to government about that? Basically, panelists, that's what we're asking.
Right, and thank you, Lynette, I agree with you.
Sorry.
Just to say that primary healthcare renewal and sustainability.
Mm-hmm.
Yeah.
If
So,
I may just add,
And
Lynette,
Mrs. Bassel, I do, okay.
oh,
Pauline, yes, and then Carmen.
yes, Lynette, I think one of our concerns in the civil society is that there is very little involvement of our sector. And when you're talking about patient-centered and access and those issues, I think what the ministry may need to do or should be doing is to engage with and involve the civil society groups that are providing healthcare. Because we know that not all patients go to the primary care centers. Some will go to the private doctor, but we offer another alternative for those people who don't want to do private doctor or the public sector. So in fact, I would recommend that the government makes a concerted effort to engage with the civil society groups and involve them, because this is one of the issues we had with the COVID. We've got our information like the general public about what to do, when to do, and how to do. And I'm really happy Carmen said that, you know, the public, the health sector groups were engaged all along in the process. And I'm really happy about that. But if we could encourage the government to broaden the base and engage, also include the civil society groups that provide services. Because as you mentioned earlier, the Jamaica Family Planning Association has two sites, one in St. Anne's Bay, one in Kingston. And altogether, we provided over 7,000 services last year, close to 3,000 people, okay? And so we had to make some changes in the time of COVID as well. Our services were not discontinued, but we had to modify. And we also have now introduced a tele-counseling aspect for those individuals who can't come in. But we really would have liked to be partnering with the Ministry of Health so that in fact we get the kind of information about what to do if early enough, and how can we in fact we continue the service delivery that needs to be done. How can we procure the equipment and supplies that we need? Because we were out there on the general market looking for sanitizing products, looking for PPEs with the general public. And so that will be one of our recommendations for how in fact the government could address the cost issue at the same time the access issue.
Okay. Carmen, you wanted to make a comment?
Yes, just to quickly say that I'm happy for Mrs. Wedderburn's question. And I'm also happy for Mrs. Russell Brown's comment. But what I want to say to both individuals and to the rest of us is that for too long, it has been us who are the employees within the healthcare delivery system who has been championing the cause along with a number of persons in civil society to say we need to have an improved primary healthcare delivery system. Because the only way to ensure that we are making it patient-centric is that we have to meet the needs of the populace where the populace is.
Mm-hmm.
And what we find out is that it is now time, I will say to Mrs. Wedderburn and also to Pauline, not to ask the government to include us. But what the populace need to start doing is to say to the government, we are now demanding that we are included. And we offer ourselves to be included. Because one of the reasons I think why the response has been so long and drawn out and not responsive enough is because those of us within health are the ones who are speaking about the challenges, speaking about the inputs that need to be in primary health care. And they see us as being persons who continue to complain, and we are complainant and we are never satisfied and we should see what we can do. But when the populace decide now to stand up and say, I think it is time that I'm able to meet my healthcare demand and meet it in a humane, a respectful manner with the level of integrity and the level of provision that there needs to be in primary care, then we'll have it. Because if we continue to leave primary care lingering, what you're always going to have is secondary care, the hospitals, which are always continually overburdened. Because what you find out is that just like COVID, Many persons got fearful with the information that was coming out. I know the information in the first instance came out to them, so it drove fear into their heart. Because for me, rather than saying social distancing, it is physical distancing for me. Because you must keep socially connected to other individuals in order to keep your sanity and to remain well and active. And so one of the things that we must do is that once we improve primary care, when we have that robust primary care, the communication will start coming out from early within each community and each district. So by the time the national level starts responding, persons who have already understood it in a way that they need to understood it and is able to cope and to carry on in the manner that they need to cope and to move forward with what they are doing. And so we must seek to ensure that primary care is able to meet not only the having enough doctors to see the patient, enough nurses to run the clinics. It can be one nurse to 60 or 80 patients for the day, having a pharmacy service that is up and robust, having the diagnostics that there need to be in primary care so that individuals can have that level of confidence that once I go there, I no longer will have to go to a hospital to get some portion of my treatment or my health need attended to. But I'm able to get it at the community level where persons can sit with me, where they can talk with me, and where they can educate me. And where also that we are back up where we have the public health persons and the public health inspectors and the nurses goes into the community to seek to have that kind of discussion and collaboration and to be in that preventative and promotive mode.
Okay, we're coming, a number of things are clustering together. And the question that they raise, for example, patient-centric, public health renewal and sustainability, CSO involvement, CSO advocacy, etc. The question that we have to ask of the strategic plan is, are those issues embedded in the framework of the plan? And it seems to me that they are not. And it seems to me that this level of discussion that we've had is asking us to take a human rights-based approach to health. And I wonder if any of you would want to comment upon this, because the issue, some of the key issues of the human rights-based approach surfaced in COVID, and we seem to be shying away from that in terms of our health planning. Anyone wants to?
Hello, good afternoon.
Yes.
Hi, my name is Andrea Christie. I'm the Director of Nursing Services at the Sir John Bowling Rehabilitation Center.
Yes.
So my response is going to be somewhat purposeful or skewed towards persons with disabilities.
Yes, and you're responding to the human rights-based approach in that context as well.
It could be viewed as that as well. So I agree with my president wholeheartedly what she has presented, and I would like to also add to that in that some of the gaps that I had noted during the COVID period. It has always been gaps related to persons with disability, but it was very vivid during the COVID period is that persons with disabilities have always been marginalized or left out as it relates to equity and equality and accessibility to healthcare. And if we're going to be approaching healthcare from a universal health coverage perspective, then we have to be inclusive for all members of the population, right? Because what I see has been happening over the years and in healthcare, as even with primary care has been focusing on, when I thought it should be focusing on health promotion, as Madam President stated earlier, health promotion and prevention. But we see a number of persons coming in with illnesses as opposed to seeking preventative measures. But there is no facility for persons with, there are little facility, let me not say directly there is none, but there's very little facilities available for persons with disabilities, whatever the disability, whether it is physical disability in terms of mobility or otherwise this disability. There seems to be a gap where that is concerned. And the treatments that are the policies that are in place are very limited in providing access and accessibility to these persons,
Okay.
right? So we need to look into that, into making healthcare from the primary level straight up for all persons, universally accessible and equality of for all, and also to engage each person in owning or being responsible for their health. That's where you'll get a better quality of life from each one, when each one is responsible for his or her healthcare, whatever level of ability you may have.
Thank you for
sorry, go ahead.
Thanks, Andrew. I just wanted to note and add to what you have said, concerns that have been posted about mental health, persons with mental health challenges, also persons who are survivors, victims and survivors of violence and abuse. In other words, how the primary, renewed and robust primary health system needs to be responsive to the host of issues that ordinary people face on an everyday basis. For example, screening for gender-based violence is something that people have been asking for, and I don't know where that is. So what does that mean, all of these concerns? Does it mean that we need to extend the guiding principles to incorporate some of these ideas?
I believe so. Sorry, just so I can conclude, I believe so. And just to note that the Nurses Association of Jamaica and the Ministry of Health through the Chief Nurse's Office, we have been embarking on a system where we call where we're trying to develop strategies or to identify persons who are vulnerable to violence, gender-based violence, women and children in particular. Well, it was stymied a little bit because of COVID, but we have identified these as gaps in the health system, and we have been putting forth our plan or preparation to assist or to improve the health sector, to incorporate systems and policies that ensure to provide treatment or avenue for these persons who are susceptible to violence. So yes,
so can I hear from my panel? Are you in support of looking at the principles and extending them to incorporate human rights issues and a framework for human rights? And briefly, just to touch base before we move on to the next issue. Yes.
Mrs. Vassal, what ought to happen, human rights, from our training, human rights have always been a part of our training. And as your group and others look at the right to access, the right to safety, that is in essence what we are saying that needs to happen, is that we need to ensure that, and as Andrea said, that we need to ensure that our persons with disability and with their special need have that level of access to the services that they need. From a nursing perspective, we recognize the gap that we have, especially, as I said, the persons with gender-based violence. And so we have been having the discussions. A number of us were trained in that regard. We had saw training through PAHO, which we got through a nursing now project, and from an NAJ perspective. And what we have been trying to roll out, and the good thing is that we now have the cooperation of the Ministry of Health, also supported by PAHO, is that we must train our healthcare providers, more so our nurses and midwives, in recognizing and treating with persons who have been exposed to gender-based violence. And what we are seeking to do, COVID has come to kind of move it from where our aim was for this year was to train at least 520 persons in recognizing and treating with the gender-based violence, while the 20 would be trainers of trainers who would continue the training. But then again, if we don't change the access to the right to access to the provision of humane, respectful healthcare services, we're always going to have that. I just think of how our healthcare system is set up, the facilities. You have one room to see patients, and sometimes two healthcare providers are operating from that one room. It doesn't lend itself to that privacy and confidentiality that you'd want. Because truly, patients come in and they'd really want to have that kind of one-on-one discussion with you. You see something and you ask them, how are you? Are you by any means being so affected by ABCD? But they will tell you no, because then again, right across the room or in another corner, there's another healthcare provider with another patient, and I'm afraid that the privacy that I want isn't there. And so we have to take it from that grassroots level to ensure that our system is fully geared and fully managed and supported with the whole human rights approach. We must have respect to the right to information, participation, access, and safety to ensure that we're meeting the needs. Our mental health persons are another set. You have a clinic for mental health persons, so you may have 70 mental health people to be treated that day. Again, 3 or 4 persons in that room. How do you now get to have that kind of discussion with your patient who is in that local moment that you can kind of have that discussion? It is more of a you come in, we give you your medication, we give you your injection, and you're gone, and we see you the next month. The same thing happened in COVID. Mental health aspect of it was one of the last aspects that we seek to recognize that we must address and address in a robust manner. And the mental health team will tell you that they were one of the last set to get their PPEs to ensure that they're able to protect themselves and to protect the patient at large that will come to them.
Okay.
In our facility, not many of us are trained in sign language to understand that when we have a person who is so not able to hear us or to speak, at least we have somebody we can call and as a resource persons or as resource persons to communicate the information effectively with these individuals, or our system does not lend for you to get an interpreter, a family member who understands, to come in and be with that individual at all times to ensure that the individual is understanding and is able to cooperate and is able to consent because he or she have been so informed. And so it has to be that we change how we organize, and COVID is going to demand that, because we can no longer have 3 or 4 persons in one small room seeing individuals, because the risk of COVID continuing and passing on to others, if the physical distancing will not be applicable, even our secondary care, how we space out our beds, how we treat with one nurse or one doctor seeing 20, 30 patients, that will have to be changed to ensure that we are seeking to the rights of these individuals, that they have enough time with the care provider to expound on their needs and that they are properly adequately addressed. And so COVID is going to demand that within health we change how we operate to move forward to meet the needs of the populace.
Okay, we have half an hour to go, 28 minutes, and I want to give a lot of space to the participants to make their comments and questions. But I also would like to hear from the panel. And the implication of what you have said is evident, that health service delivery can't be only a question of network, but it has to be in terms of principles and issues that are dealt with, which the plan does not sufficiently talk about, those human things, what's going to happen. This, a framework doesn't necessarily mean that I will be treated in a more humane and respectful and human rights centered basis. But before we open the panel, I'd like to, before we open to the wider audience, I'd like the panel to talk about the financing of this thing. For example, there are very laudable objectives all around in terms of keeping our nurses, our medical persons here, ensuring that the workplace is positive, environment, etc. Can we talk about financing? We're talking about access to health. But access to health is not only what happens at the clinic, but access to the aspects that go to good health. So if I don't have water and sanitation, for example, I can't have access to good health, as COVID so clearly showed up. So what is the approach to financing that we need to take? Just the approach. We know we might not be able to say specifics, but what kind of a thinking needs to inform the financing of health? And I'm asking my panel to start off.
So, you have a few, if I may.
Yes, please.
you have a few things that you'd have to look at. You have to look at the efficiencies in the system. You have to look at how are the funds being used currently. We spoke about GDP before, and that we want to be at 6% for health. When you look at other countries, they may be having a higher percentage GDP for health, but they are not necessarily achieving their goals in terms of healthcare delivery. So you have to look at how efficient you are going to be with the money that you have. You have to look at human resources. So looking at staffing, how you're going to mobilize persons so that the system can work for you. Maintenance has been another issue, especially for equipment, and how do you maintain policies that you have in place? How do you adjust over time to make policies better, efficient? But just throwing more money at a problem is not necessarily going to solve it. You have to be you have to look at what you have in front of you and be efficient with the funds. The National Health Insurance Plan, I think it's a very important plan for us, but we have not seen it roll out fully yet. We have seen where a lot of money has been spent in drafting the concept and coming up with it, but we have not seen where it is anywhere near yet to be rolled out. So that is a good place to start with looking at how we're going to fund the health sector with the use of the National Health Insurance. We need to look at how we're going to pay for it, how is it going to be utilized. But I think right now we need to look at the funds that we're spending. Are we really getting value for money? That's the first step. And then look at the critical areas that you want the funds to be spent in to get the most out of the system.
Okay. Any other panelists before I throw this very question to the floor?
Mrs. Vasson.
Yes.
I think the government and us have recognized that the government cannot continue to be the payer, the provider, and the supplier. And as Dr. Tom said, it's full time that we seek to put some real legwork and concerted effort in getting the National Health Insurance Plan going. Once we continue to have the government being the provider, the payer, and the supplier, we are going to always be in short change for health, because the same money, same budget that they are using to pay the employees, provide the service, meet the needs of them, ensure that we have the facilities maintained, then we are always going to be shortchanging the populace.
But Carmen, isn't
it 20% of the populace that have health insurance? So we need to move it to that level, decide whether it's the government who is going to fund the health insurance for populace, or as we had brought in the NHF to seek to address that portion. How do we now increase the level of support that is now being given from the NHF, rather than being using the NHF also for your capital expenditure and your recurrent expenditure? But how do you seek to ensure that it is managing to ensure that it is addressing the needs of the populace in providing that level of health care?
Well, I must tell you the truth. My friend and supporter, Mila Thame, and I were looking at this whole business of the different funds and so on, and how these funds are sustained, not even sustained, what goes into them. And the question that we came around asking were, one, are these plans feasible in the context of a population whose income levels is at a minimum stage in a country where the majority of persons who are working are in the informal sector and are not a part of any system that is contributing to taxes and the like. Also, where people can hardly meet some of their basic needs, much less talk about making contributions to other areas where, for example, funds that are taken from, say, I understand tobacco, revenue on tobacco goes into the National Health Fund. But to what extent can you continue to tax those areas? In other words, we were saying that this whole business of the national insurance and these things really need a big conversation among the people, and it needs other transformative actions that will help people to make a better living so that they can afford to invest in health. So it's not only an issue of health, but it's in terms of economic development, restructuring, and all of those issues, because health is not only, a lot of things impact health. So I don't know. But is there any other participant who has any comment on this issue of financing? Nobody has touched the matter of the debt, for example. Is it realistic to expect that our economy will have more to spend on health or education or any other area if we remain so loyal to this onerous debt and not seek to renegotiate debt rescheduling so that we can get a space to breathe in order to help the population to improve its conditions? Is there any-
Judith, I would certainly recommend that we explore. There are other countries that have begun to do it. Our debt to GDP ratio has improved, but only slightly. We have, if that is a strategy to maintain a minimum level of expenditure on primary health care and all that we understand by that, then I think we should pursue it.
Yes, thanks, Judith. I saw Carol.
Yeah, thank you, Lynette, and everybody for a very interesting conversation. I really think that the debt continues to be the elephant in the room, in the national room. I think that there is clearly some reticence continuing on the part of our governments to renegotiate debt in any way, but we have the experience of the debt exchange. I recall when the debt exchange was first put forward as a possibility, the then Ministry of Finance and Minister were similarly cautious, reticent, feeling it couldn't be done, thinking that the debt holders would not countenance it. And yet we did it, we came through it. Just as every individual now who has a loan somewhere has had to go to their banker and say, boy, banker, how are we going to reschedule this? How can we reorganize the payments so that I can make it through and you can actually still collect? I think the nation is faced with the same need to have this conversation with its debtors, with its creditors. So I don't know. I don't see how we're going to have fiscal space for maintaining minimum basic increase, perhaps in health and education, without revisiting the debt situation. And since I'm on the floor, if I could just very quickly ask the panelists, both Nurses Association and Dr. Thompson mentioned the backlog as a result of COVID, the fact that many people with their comorbidities had not been seeking medical care, and the backlog in elective surgeries. So I wanted to just ask, what is the plan? I mean, what are the various professional groupings saying to the Ministry of Health? That what's the game plan? Are we going to wait for the avalanche to come, or is there some discussion that has already begun about marshalling both human and other resources to deal with the backlog?
I'd like to just pause a little in your response, panelists. I just want on terms of the financing thing to emphasize the points that were made. Joan Grant Cummings wrote about it as well, that we must put on the table a debt for health swap. It's the same thing Carl is talking about, but it definitely needs an examination in a fulsome kind of way. But because we are very quizzical and civil society is not convinced that 6% is feasible under the current situation, nor a lot of the other things in the plan for that matter. But can we get some response to the question? What is the plan to deal with the people? I know people who have said that they have these ailments, but they haven't gone, or their operations have been rescheduled. What's going to happen to address these?
That's a very good question. I mean, in the hospital setting, for sure, I mean, we can only see who comes to us. We will just have to try and triage most urgent patients to be done within the constraints that we have. Well, the JMDA certainly has contacted the Ministry of Health and asked them, how are we going to move forward? We have just, gotten some guidelines for patients, elective cases, elective surgical cases, in terms of how we're going to manage those with COVID-19 testing and how we, deal with patients who are going to now come in for elective surgery. But I don't know what else the government has planned in terms of putting in place, stop short of building a new hospital and getting more staff to do the backlog of cases. It's just a difficult time for everybody, and it's really unfortunate for persons who have been at home and they may have malignancies growing that they don't know about, or other problems brewing that they don't know. They're afraid to move because they're in a vulnerable group. It's really, really sad what the potentials for are coming in the future. But we have to just be committed to help persons in the health sector as best as we can when they come through the door with what we have available.
And just to add also, Miss Basso, what we know has commenced since the 1st of June. And before is that what has been done is that some persons' appointments have been rescheduled. But so though it may be a longer appointment, they have not been forgotten. So they have gotten a rescheduled appointment, and some areas based on the guidelines have recommenced surgeries since around the 2nd to the 3rd of June. So some persons' their surgical need has been attended to. And in many areas, the outpatients clinics have resumed in some areas, so persons are being seen. From the primary healthcare level, what I do know is that the nurses and the others seem to have sought to engage themselves in different groupings to ensure that where the public health nurse has to be out, then the nurse midwife or the midwife is seen to the other clinics to see how those needs can be met and how you get back to a level of regular functioning. One of the things that we have suggested to them is that they will now have to go back, just like what they used to do with immunization, where you now have to track those who have defaulted from the clinic, that you go back and look into your books to see those who were coming and those who need to come but have not been coming, and to see how you reach out to them and to find out what is happening, and also to seek to do that kind of tracing. What I do know also for some public health persons in some of the communities where they have been doing contact tracing for COVID, they have also sought to use that kind of interaction to speak with their patients who they know they have out there who maybe have not come in, or those who would want to come in, to seek to educate them as to what to do, when to do it, and how to do it.
And just to be clear, I was speaking about that person who has not entered into the system yet.
No.
Right. So the persons who are already in the system, we our KPH clinic has not stopped. We try and see the patients who come to us, and we try and make sure to encourage our patients to call them and encourage them to come in if it is that they have scheduled appointments that they can't miss. And we try and reschedule as best as possible those patients who have non-urgent outpatient conditions.
I guess at Jamaica Family Planning Association, Lynette, we noticed in March we had just about a 60% decline in our client load. What we, by now though, those people who missed their appointments have in fact been rescheduled and have been covered. And remember, we deal with women and men who have family planning needs, antenatal clients and postnatal clients. The postnatals were not so much of a concern for us. The antenatals, those who didn't come in, we reached out by telephone to them to do as much counseling as we could by telephone. And then once the lockdown was lifted, then those women started to come back in. So now we have in fact covered everybody who had an appointment in March, April, May. All of those have been covered.
Very good. I want to ask this question. We don't have a lot of time left, but it seems to me that we are saying that the path ahead is going to be very challenging for all we are saying, right? Post-COVID.
Sorry, Lynette.
Yes?
There are two hands up currently.
Yes?
We're saying
I couldn't see them,
Lady
sorry.
Spence and there's Ingrid.
Yes, okay, let's take those and then we'll end with, okay, let's take those two. I can't see the hands, sorry.
All right.
Ingrid.
Okay, hi everybody. I'm just very grateful to all of you, both in to the government and the NGOs, and what we've been doing. And really pleased to hear that you're all reaching out back to the people to try and keep them in the loop and to come in for their treatment. So I just want to say a big thank you and shout out all of you, because I know most of you must be totally exhausted. I don't know how you're going to organize your own pacing and care, but I think that is an important element for us to look at, because you just cannot keep going. And I read an article in a journal recently that was actually also put in the New York Times a couple days ago, where the heads of the two #1 hospitals in America stated that based upon their research, as many people who have died in COVID, and there's a lot over there, have died from not getting the care that they needed. And this has been documented because people have been afraid to go to the hospital. There's been not enough space to accommodate them, and all of this. I think the government has to take a proactive approach in its education work to say it is important for people to reach out themselves and check now, because there's a limit to how long you can postpone what you think may be elective, or because you're afraid that if you're going to the hospitals, you're going to die from COVID, you're going to expose yourself. I've been waiting for a kidney transplant, and I had an education session with them, and I was interested that they were encouraging me to come, even now with COVID. And it's subsequent to that I found out the amount of increase in death that they have recorded, which we have not even had the time to really track in Jamaica with all of what we're doing. That's the first thing. The second thing I want to say is I am really pleased to hear Lynette and this group of women trying to look at the financing, because it's one thing to say you have a right to this and you have a right to that. It's another thing to be able to make it a priority within the societal priorities for funding and for financing. And I know from our experience with the maternity leave, if we did not get people as a group, really mainly of NGOs, to sit down and look at the financing and say to them, these are how many you're going to need, this is what we can do, and make concessions, but also make demands as you are all making, it would not have been a reality. So I think I'm really pleased to hear about, is it Malika? Or whatever, and you need a subcommittee that has those strengths, just like how you have the technical health strengths. You need people who will work with you to make the health be a priority in our society. And finally, just to be quick, in making it a priority, it's not just for the government to provide or whatever. if we don't recognize that in our own personal taxes, expenditure, that health is, all of our other goals in life are really going to hang on how healthy we are, then we are not going to have the confidence to make the sacrifices or to demand that society make the sacrifices, either ourselves or as a collective. So that's just my comment. That the committee, this group, if you can continue that work and pull in the resources you need. People know about the economy, about the debt for swap for this, the insurance, whatever. What is the mix of funding that we are going to need to, along with the activism, get the changes we want. Thank you very much for allowing me.
Thank you, Ingrid. Yes.
Yeah, Lynette, Nadine, I wanted to comment on two things. One, this whole issue that you touched on, which was the human rights approach to healthcare, and I wanted to ask that perhaps of Dr. Thompson and Nurse Johnson in respect of, I think that there's a lack of human rights focus in the training of nurses and doctors and other healthcare providers in Jamaica. I don't know if you remember when we had the infamous dead baby scandal, and these reports, these intense reports were done of each medical facility in Jamaica. And they revealed some really very disturbing realities that were present in our hospitals. And a lot of them were as a result of poor leadership of hospitals and poor governance arrangements on the regional boards. And the issue of governance and leadership of hospitals and regional health boards came up at that point. And the state of the hospitals, and just generally some of the issues that, yes, I understand the broader issue of finance, but I think there are some other issues that are perhaps low-hanging fruits that we need to focus on, such as what corrective measures were taken when those reports were submitted. And some of them didn't require extra finance, they just required people to do their jobs. And to also, ask of the practitioners, what can be done in respect of the training of nurses and doctors to ensure that they get a better grasp of the idea of how to treat people who are accessing or who want to access healthcare?
If I may, I love how that question is. It's a provocative question, and I love it. The thing is, the doctors in the public health sector, they are employed by the government. And I've been president of the organization, this is my 4th year and last. And I've been saying for 3 years now, as far back as I can recall, that we ought to have something in place. And the strategic plan speaks to it. A patient-centric approach, and we have training for all levels of staff to ensure that we don't have any issues with customer service. I call it customer service, right? That everybody is entitled to the same level of quality care. And I've said it to them. And I keep hearing that I think it's a compassionate care program is supposed to correct all the ills in the system. And I keep hearing this. I don't see it happening. And I really think a serious approach needs to be taken to how we deliver care to people. I hear it in the tone that there is and I agree with you. There is a serious problem in how we deliver care. Doctors, nurses, every level of staff. There's a serious problem with training. And I think it is the government's role to offer training for persons, because there are persons from every aspect of life who come into every single profession. And I think it is important that we have a training program that teaches persons how to deliver customer care to people, right? All levels of staff, nobody is immune, all levels of staff. Once you start working at an institution, you have some form of training, and you cannot start working until you have a certificate saying that I have been trained to deal with patients, right? I think it's a serious problem in our institutions. You're correct. It doesn't cost any money really, right? All they need to do is just have the program in place. So I hear about the program, the compassion. I keep hearing that narrative being given to me as the solution to the problem. But I don't see where it's implementation and it's not being effective. And we need a quality assurance program. Again, the strategic plan speaks to it, right? There is very poor quality assurance in terms of in hospitals, right? And it speaks to management. And as long as we continue not having these things in place and we continue to be reactive, then we will not get to the point where we need to be.
Okay, so my final question is this. In terms of pulling these last comments together, in terms of management, quality assurance, accountability, and the like, what needs to happen to redress the issue that led to Jody and Farron's death? What are the gaps that need to be filled? Because we cannot end this discussion without recognizing that she was a big part of the face of COVID and our experience. And she represents a situation with maternal mortality that is not improving in Jamaica as we speak. So what needs to happen in terms of management, quality assurance, accountability, and the like, in order to make sure that that doesn't happen again? Does it cost?
Chair, my answer is going to be very short. My answer is this: we have to make sure that we demand the report, because we heard that the report is going to be forthcoming to us, right? That's the first step. We have to get that report from the inquiry work that was done, right? We have to make sure that we get that report. We may not have the details to protect the patient's privacy, but we must get a report of really, what led to this happening, right? I have, it's very disturbing, but the first step is to get that report, right? It should never, ever happen again. And I think, I will personally reserve my comments until the report is out.
Okay, Carmen and Pauline, any comments?
May I just say, Miss Vassell, one of the challenge I think that occurred is that though we started the public education early, we missed the opportunity of paying real great emphasis on the communication to all staff members, ensuring that the communication is up and robust. We have a system where, though we said, let us get ready, the resources were not present, and the resources not being present, while at the same time you did not have that facilitation where the organization had the ability to help staff to adjust to the new roles, to adjust to the new expectations, while also acknowledging and addressing the staff's concern, their fears, their personal issues. And I think what did happen was that not being able to put the facility and the employees in that kind of position created the challenge with the system issues that pre-exist within the system.
Pauline, you have any comments? Okay.
Like Elon, I am going to reserve my comments. I am baffled at how in this day and age that could have happened in Jamaica. So I'm going to wait for the report to see what really was the process, where did things break down?
Yes.
And therefore, who needs to be accountable?
Right. So in summarizing, the correct, yes.
Before you summarize,
yes,
there are two hands up.
Yes.
I'm seeing Carol and Joan Cummings. Probably it could be the last two persons.
Okay, yes, thank you.
You're welcome.
Actually, beg pardon, I should have taken the hand down. I spoke.
Oh, my apologies.
Yeah.
Joan?
There's Joan.
Is she muted?
All right. Just as Carol asked last week, what is our philosophy in terms of health? It's not really, they're not the little mealy mouth phrases in the vision. What is our philosophy really? Is it a resource for living, as the PAHO says? The second thing that we really didn't talk about, and which Peggy reminded us, we are being subjected to this neoliberal agenda with regards to finance. And as long as we buy into that, our system is going to be one where it's a universal based system. It's going to keep on having those inequities. It's going to involve fee for services. How do we discuss the neoliberal agenda as a part of the change process in health and other issues like education, etc.?
Thanks, Joan. And that last comment just goes into the package of issues that Ingrid was saying should be looked at by that core that is addressing issues of health, the constraints and so forth, and what are the possibilities within that. Are there any more hands, or can I? It's now 3:35, and I really do want to thank you all, learners, patients' rights to comment and access healthcare and have access to system of redress. Yes, Lorna, she wants, that is an important point of focusing on patients' rights as a whole category that would fall into the principles that are here. And this is the whole question of patients' rights as human rights. Human rights in patient care is a big part of the work that is being done by the Partnership for the Promotion of Maternal and Neonatal Health that is being implemented by the University of the West Indies and ROC, and Lorna Lee is chairperson of ROC. So that whole business of the promotion of patients' rights, I'm glad you got it in and we put it in at the end. I just want to say how gratified I am and thankful that you have contributed so fully to this discussion, and to say that if there is one takeaway from this conversation, it is A, that this is a big continuing conversation, B, that there are some issues that demand accountability, and the whole question of the report on Jody and Sferron's death is an important element of that accountability that we want to see in health, because it resonates with some other critical issues that we have discussed, including the continuing problems of maternal health, maternal mortality that we are not currently achieving. The third element is that there are some issues that we feel that needs to go to strengthen the health service delivery network with a focus on a renewed and sustainable primary health system that speaks not only about structures, but speaks about relationships and ways of working that give primacy to the human-centric, the people-centered issues of development. And what I want to say is that we really feel that we have our handle on an issue that is of interest to a wide cross-section of persons, so that our cluster, our company of women, as I call us, has something to chew upon and to help to build out a program of work for advocacy. So that I want to finally thank all my panelists who have really contributed so wonderfully. I want to thank all the participants, and I want to thank this technical support provided by our dear friends from We Change, who have not made me feel nervous, because I think I was prepared, because I'm no techie buff, right? But I have felt very, very supported in this process. And I don't have the announcement on what is coming next week, Friday, but you can be sure to be.
I can tell you, it's COVID-19 and the Jamaican labor market, a decent work agenda for Jamaica.
Excellent. So next time, next week, same time, same place, we invite you to come back and help us to flesh out this agenda. You know, we have elections coming up, you know, and as women and men and persons who have a consciousness of our development needs, we need to put ourselves in a place to develop our package of demands to trade it in the marketplace of politics. So thank you all very much and all the very best. God bless you all.
All right, take care.
Thank you, Lynette. Thank you very much.
Also you. Thanks, everyone.
Thank you.
Thank you, Lynette. Well done. Good session,
Thanks everyone
folks.
for
Thanks to the
participating.
panel.
Thanks, Lynette.
Well done, everyone.
I really like on the panel. Thanks to We Change.
Great discussion. Thanks for the voice.
Yes, thanks for the session. Very good
Thank you.
session.
Thank you. Why this lady don't learn to dress properly? All the meetings she comes to, she behave like she's at her home and she's a big woman. But she's in.
Carmen, stop speaking. I can hear you.
Muted.
Mute yourself, Carmen.
You're not, Carmen.
Hearing you quarreling.
We're hearing you. Gosh.
He's very displeased, whatever it is.
Next week, Friday is Friday. What time? Friday.
Okay, guys. Thanks
Friday,
so much.
May 19. Huh? 20, from 2 p.m. to 3:30 p.m. She said yes, sir. Helene Davis White. Look if you find a picture for her.
Lynette, there are a number of comments. You can take your time and scroll through if you'd like to make any notes.
Read them, Stephanie.
Oh, read some of them?
Yeah.
Let me go. All right, so a lot. I was saying strong public ed, frequent official public updates, presence of active island-wide network in health service, getting relevant health stakeholders on board, collaborative approach appeared evident in many places in health system, priority treatment as needed was given to the situation, leadership was present. Oh, these seem as the positives. The gaps. Okay. There's need to increase the national budget allocated to health and to integrate gender in health policies and programs. There are gaps in holistic approach, waited and did not close border until it came upon us. Strength, despite the gaps, the system showed flexibility and responsiveness. There was a question, sorry if this was already covered, but could issues of domestic violence and child abuse also be encompassed in public health? A positive, the private sector jumped on board with whatever supplies were available, rubbing alcohol, sanitizers, making masks, etc. That was a question. Another gap, management of all information. Example, people became so frightened. Some with critical illness did not go for regular checks. Added to fact, private docs withdrew service has resulted in some deaths. Okay. Gaps, had experience of ambulance service during the period and watched personally handle a critically ill patient and had meager covering. With amount of handling of patient necessary, if vivid was there, they would have caught it. Oh, if vivid, there they would have caught it. We also need more investment in community-based mental health and counseling services to deal with psychological impact of COVID-19. All right. What does equity mean? How do we see or treat people living in poverty? People with disabilities, women, LGBTQ people, children, older persons, young women. That was a question. Going through. Somebody made a comment. Respect for privacy goes out the window when we use public facilities. It is assumed that once you are present, you have agreed to share personal information with all here nearby and every HCW. We need 3 shifts that allow 24-hour service in real life, and not just workers that can get extra shift to earn more income.
Great.
So the populace can access primary health care on any of the 8 hours they are scheduled for. Now we have people who have emergency at certain hours to get some attention. Regarding the funding, we have to get more behavior change to much hustle and bribe mentality, or that is too much hustle and bribe mentality.
So can we get those comments? Can you just send them to us alongside with the tape so that we can do this? Look at your summary.
The comments?
I'd love to use the comments to categorize, to help to flesh out the report.
So the reason why I asked Stephanie to read it is because we are now recording the comments.
Yes. And I was going to suggest that I could screenshot them.
Yes.
And put it in our email and send them to you.
I would appreciate it. Finally,
right,
how many people participated?
The maximum I saw was 55.
Okay.
At one point.
Excellent. Okay.
Very good conversations, though.
Yes, I thought so.
I believe so too.
A lot of things that we could have gotten down into a little bit more if we had more time. But
Yeah, man, it was good.
Yeah. Thanks, Lynette.
You're welcome.
Take care, everybody, and thank you. Thanks, Stephanie.
Great conversation. Yes. Thanks, Steph. Hello, Nadine. How are you doing?
Hi, John. You ready for our meeting at 4:30?
I'm so hungry.
When you have
to eat.
You have 45 minutes.
I'm all right.
And I just sent the link. I'm going to do the agenda now and send it as well.
All right. Thanks.
All right, later.
Thanks, Nads.
Yeah.
Later. Bye.
Come off, never leave.